In this week's breakdown, I'm going to be covering how you can really help someone that has a rotator cuff tear get better with conservative treatment and avoid surgery. Well, what's up, everybody? Dr. 𝘠𝐤𝐼𝐴 here, creator of the Peak Method and founder of the Soft Tissue Revolution, where we teach massage therapists a new treatment method that focuses on working smarter, not harder, allowing them to make well over $100,000 per year with less than 20 hours per week of time in the clinic. So I recently had a family member that ended up having a shoulder injury that was confirmed with MRI of a partial tear of the supraspinatus tendon. There was some tendinosis in the other tendons as well, some damage to the cartilage, having a lot of pain just lifting their arm up, trying to move it across. It's been a chronic problem for a while, and one day they just kind of reached and it kind of broke and caused some problems and caused a lot of pain, and wanted to get my viewpoint and my standpoint about how to manage it conservatively. So whenever I'm assessing an injury or if someone needs surgery or if conservative care is going to work, one of the main questions I always ask is, was there trauma or wasn't there trauma? In this case, there was no direct trauma. So that usually ends up being very positive for a conservative approach, especially a soft tissue approach, because when there's a lot of trauma, a lot of times that can just tear right away and they just need to have surgery on this. But when there's no trauma, what we're finding is there's a lot of compensations, a lot of things that are getting beat up because other things aren't working correctly. So usually when I see that in my history taking that there wasn't any direct trauma, I'm a lot more confident that they're going to need conservative care versus a surgical intervention. So this family member really wanted to avoid surgery. In all honesty, rotator cuff surgery does not do very well, specifically when people haven't had a direct trauma. Usually what happens is the supraspinatus tendon starts to tear. The surgeon says, we'll go in and fix that and patch it up, but they never really ask the questions and really figure out why that happened in the first place. And they'll go fix it, but the other problem is usually there and it comes back. So rotator cuff surgeries actually have a very, very poor long-term outcome, especially if there's no direct trauma associated with it. So what I want to show is kind of like my whole thought process and go through what I treated, what I saw, showing my objective real data and real measurements so you can see. So the first video we're going to show, this was a pre-treatment video when we first did the assessment, and you'll get to see how limited that range of motion is and how painful it is. You can see in that video, it's just very painful. They're having to work really hard to just get their arms up basic, working hard to compensate through all that, and it's just not a good overall range of motion. So what we did first was I just really wanted to unload the infraspinatus muscle. Infraspinatus is so key in overall shoulder stability, function, and pain. So what I want to drop first is actually a demonstration from one of our continuing education courses of me treating the infraspinatus, and that's exactly what I did for the very first treatment. So now we're going to go over infraspinatus. Infraspinatus is a very important muscle in shoulder function, shoulder stability. It's really important anytime you're pressing or reaching or going to grab things, and a lot of times it becomes very dysfunctional. Now, a lot of therapists make a bad job with this because it's actually very superficial. It's not deep. All that's really between that is some skin, a little bit of subcutaneous fat, and then the muscle, and it sits right there. But the weird thing about the infra is there's like a 45-degree turn of the scapula. So what happens is people are way too compressive and they go in there, and in order to break that scar tissue down, you need proper depth and proper tension to get in there. So the first thing is you just want to get in there and actually be able to palpate it, because if you can't find it, you sure as hell can't fix it. So the way I like to palpate that is I'll have them bring their arm up and just bring it straight across, just like that. And then what this will do is I'm going to kneel down, is I'm going to have a couple landmarks. I'm really big on bony landmarks and finding our place. So the first part I'll find is the superior angle of the shoulder, and then across here goes the spine of the scapula out through here, and then down through here is the lateral border. Where the infra lives is right in through here. And usually where you're going to find dysfunction and scar tissue formation is usually right in the muscle belly and through there. So now I have that set up, and I'm going to be able to palpate. And in order to palpate, what I like to do is get my arm set up just right to dictate the motion and the line of drive. And what I'm gonna do is actually face at like, I call it like a negative 45-degree angle, where my line is going to go here and I'm gonna go here. So what I do first is I get in here, and a key thing here also is I have my fingers go across, and my hand and my thumb is almost like pointing down. A lot of times when we treat, we're here. This one's different. This allows you to keep that line of drive in your elbow and in through your thumb. So now I'm here, and then the next thing I'm gonna do is I'm gonna lock and key that, and I've talked about lock and key before, but basically you're gonna go in here and let it sit in there, and you're going to start to just get in there and do some compressive palpation to find where that muscle, and I'm gonna remove my hand so you can see it, and I'm gonna go in there and feel where that muscle isn't compressing, and right there is where that scar tissue is. So what I'm gonna do next is I'm just gonna go a little bit lateral to that, and I'm gonna be here, and I'm not gonna use my hand on this first one just so you guys can see it. And what I'm gonna get first is I'm gonna get some depth with my body, and I'm gonna back out about 10%, and then I'm gonna get some tension about a 1/4 inch into that scar tissue, and that's how I'm gonna load that up. So the motion for the client is they are going to start their shoulder just like this, and then I'm gonna have them bring their arm straight across just like that. And when it gets close here, I'm gonna have them grab on their elbow and just pull it just a little bit, just enough to clear their chin. It's not a race to like yank their arm across. It's a very easy, slow, gradual motion. When it gets close here, I'm gonna pull it just a tiny bit over. So now we know where it is. We're gonna set it up. She's gonna be here. I'm gonna approach at that negative 45-degree angle. I'm in here, my hand is going straight across with my fingers. I'm here, I'm set up, and my first way to get my depth is going to be a lean with my body and a little push with this opposite pec. So I'm gonna lean, push in, back out about 10%, and then my tension is going to be a lean with my body. I'm gonna pause for a second, and then she's gonna go ahead and start that motion. Go ahead. And it's called internal slide. It's just coming to me, and we're moving it. Keep going, keep going, keep going. And you're just gonna feel that tissue slide underneath you. It should be a very gradual build up as we're doing it. If you feel it pull right away, you're usually too compressive. This needs about 8 to 10 ounces of force. That's not a lot, but it needs the tension in the right area. So make sure your body is lined up. You're lined up for success, because if you start getting your elbow in different places, you're not going to be able to generate enough force, and it's not going to be an effective treatment for your client. So that's the video for treating infraspinatus. One big caveat of my system is we always test, treat, retest. We always want to have real, sustainable, objective results. So all I really did for this client was I probably did about 5 or 6 minutes of direct treatment just on the infraspinatus. And what I want to show next is the post video of that treatment. So we're definitely seeing an improvement. It's not like night and day where it's like, oh my gosh, but you can see the motion is a lot easier, less compensated. I always say treatment is like a medication. You want to give enough to be effective, but it can actually be over effective if you do too much. So I always err on the side of caution, especially when I'm dealing with tears or advanced degeneration in there. So many practitioners want to do the kitchen sink approach and try to treat everything all in one visit, and then you really don't know what's going on, and you actually get diminished gain. So all I did for this treatment was just do the infraspinatus for about 5 minutes, and you can see that that looks a lot better. I take a victory on that first day. What I'm always looking for is just sustainable results per visit. I try to get about 5 to 7% better per visit, and that is definitely in that criteria for this first treatment. Well, 2 days later, we did another treatment, but the way my system is set up, we always start with a pre-treatment test to see how we did. So this next video you're going to see, we took this after 2 days off, and we wanted to see if we held some of that range of motion and some of those changes. So I'll link that up right now. You can see that's already looking better. It actually improved from the last visit even more. And as we start to break down that scar tissue, start to restore some range of motion and function back to that area, the shoulder can start functioning how it's supposed to be. So on this second treatment, what I did on this second treatment was I treated infraspinatus again. Then I went in there and actually treated what's called the posterior 𝘗𝑚𝐤𝐴𝑡 capsule. So what I want to show you next is a training video of me treating the capsule directly so you can see what that looks like and how focused I got in there. Once again, we treated infra and we treated capsule. So in order to find the capsule, it lives back through here. And where it lives is between the tricep and between the posterior delt. So what happens is people usually end up being too far posterior on the tricep. See how that doesn't feel good? Or they're too much on the rear delt. So what I like to do is I like to use some landmarks. So I'll hold it right here to kind of palpate it. And then I like to open it up a little bit with some of that flexion. And then what I do is I'll go in here and find the humerus. So I'm like humerus, tricep, humerus, tricep, humerus, humerus, and I'm just going through and trying to figure out, because this is when I start hitting into the delt a little bit and I can roll it over here, here, and then where that capsule comes in is right there. Is it tender, Jess?
The compression is tender.
And the capsule is going to be tender because it's a ligament and you have to get on it. Now the difference between the capsule versus any other treatment on here is we actually don't back off once we get depth. We ought to keep it. It's still internal slide, but when we go in there, we're going to go straight in with our depth. So I go straight down here, but I don't come out for my tension and from my depth, and then my tension is right into it like that.
So you're heading towards the lateral aspect of this?
I'm just going right into, right up into the capsule, and it's a very short movement. And you'll feel where that humerus comes. And it's going to be a little tender. And then basically what I do is I get my depth in, and then I get my tension, and then my motion is going to be to bring it back just like that. See how that builds up, Jess? Here we go. Here, and I'm just bringing that arm back towards me. And it's going to be very tender. And then I drop it in just like that. And then with the capsule, what I do is I lean and I hold it for about 10 seconds because it's deep. You okay?
I only felt it in the beginning.
Yeah, and that's what you'll feel is that it's just sensitive, because a lot of people, especially when she has limited range, it's going to be inflamed in there. So the key is this breaks all the rules. Like normally it's depth, come out, then tension. She goes right in there and opens that up. So as you're getting used to the motion, it's hard. Remember what we always said, I hate having my thumb out in space when it's not protected. Normally what I want to do is, and if it's bad for the client, they got to move it for you. And I mean, you got to move it for them. Ideally, I'd like the client to do the motion for me, where she's going to bring it straight back just like this. And what I like to do is just try to get that. So I'm going to show you what it looks like here. So just hold that there. And then, like I said, tricep, delt, tricep, delt. Now what I can do is now I can really get in there with both hands backed up. And now I can get a lot more. So my depth is with my body and my tension's here. And go ahead. And then what I can do is I can use my hands to bring that back just like that. And now I can really lean in. And that really helps me generate a lot more tension. Yeah, holy shit. Look at how much better that range of motion is, how much better it's moving. It just looks like a much easier motion, and the client isn't having to work as hard. And what we're really trying to do is clean up the rotator cuff around that muscle to make sure that we get the pressure off the tear, because the tear can never get a chance to heal up if we don't fix the other compensations around there. So the take home here first is we must always restore range of motion first. There's an order of operations to fixing a problem, and number one is we need to restore range of motion. And the majority of musculoskeletal injuries, there is a scar tissue component in the muscles, in the nerves, in the ligaments that makes that muscle weaker, less flexible. We get proper depth, proper tension on there, and go in there and break down that scar tissue and restore that range of motion first. Another caveat is treatment must be safe, effective, and durable. Most treatments out there are pretty safe. Effective it's kind of how you judge it and where you look at it. Are treatments effective? Yeah, anyone can make you feel better temporarily. So yeah, treatments are effective, but the key component, which majority of treatments out there is missing, is the durability component. Like, not only did we treat this, but 2 days later it held and it was better. So this treatment is very durable because we need to get long lasting results. Another component that I look at is just objective measurements. We want to make sure that we have objective data. You know, so much of musculoskeletal care really just focuses on like, hey, how do you feel? Like, that's important to me, but it doesn't tell me everything. Like, if her shoulder was here and now it's here, I know objectively that I made a difference in that treatment and that it held up over a course of a few days. So we know that it's actually making a change in the tissue. So I only was able to treat this twice because I was vacationing and seeing that. But what I probably would have ended up doing is I probably would have did about 6 more treatments on the rest of the muscles in the rotator cuff. You know, more work on the capsule, more work on infra, definitely some work on the subscap as well. And usually with my shoulder cases, I'm treating not just the side that hurts or is dysfunctional, but both. They kind of go hand in hand with each other. Then my next cleanup would have been into the thoracic spine, specifically like from the T1 to about T6. Those kind of tend to go hand in hand with shoulder injuries and shoulder dysfunction. And really, they need to kind of be cleaned up together. Now, my goal first, like I said, is always to restore that range of motion and get as much function back as possible. Then we would have got into some corrective exercises to build up some of that compensation and balance some of that strength. But you must restore range of motion first. It kind of be like building a house and trying to put the roof on before you lay the foundation. I hope you got something out of that video. You learned something, kind of looked at my thought process and the whole idea of my system about quick, safe, effective, and long-lasting results, and wowing your clients with objective data and really showing them that they are getting better and they're making improvement, and helping them understand that like surgery should very rarely ever be an option. It should be the last option if things are really bad, but understanding and correlating the data correctly, that if I don't have a lot of trauma in here, this is someone that I can really help and go in and clean up some of that dysfunction. So if you like the video, give it a comment, like, a share, share it with someone else that you know can help. Go grab our free training, come take one of our courses, and I appreciate you guys watching. We'll see you on the next one. Bye.